I'm delighted to introduce Dr. James Faulkner from the University of Winchester. James is a reader in sport and exercise physiology, and he also leads on the formal collaboration between the University of Winchester and Hampshire Hospitals. And he's joining us today with some of his colleagues to showcase some of the research that's being done by the university. James, thank you for joining us. Would you like to kick off?
Yeah, thank you, Claire. So just before I get into the presentations, as already mentioned, I'm a member of the Hampshire Collaboration Health Research Group, which is led by Professor Simon Jobson from the university and John Ramage from Hampshire Hospitals. And we're basically tasked with developing research collaboration between Hampshire Hospitals and the universities. We've had a memorandum of understanding for collaborative research and education for over 3 years, which formalised an original partnership which was approved in 2013. Although there's plenty of challenges for us to overcome with regards to developing appropriate infrastructure to help underpin high quality, impactful research, both organisations that are passionate about collaborative research and developing research strategies that complement the potential for future growth. Today, we have 8 short presentations or pre-recorded presentations, which highlight some of the collaborative research activity to date. There are also some additional presentations which will take place at lunchtime, which are provided by Dr. James Belzy on knee preservation research, some information around the Help Hampshire Stroke Clinic, which is a collaboration between the university and the Twyford ward, and also a further presentation on equipment capability from the Department of Sport and Exercise on health research. So to start off our first presentation, it's led by Dr. Margaret Husted, who is a senior lecturer in health psychology in the Department of Psychology at the university, and she also leads the Healthy Lives Research Group. So this should be the first presentation.
Hello there, and welcome to my short presentation for the Research Collaboration event. I'm just going to give you a very brief introduction to myself and my research, which predominantly covers the areas of patient experience, changing behaviours, and improving well-being. So who am I? My name's Dr. Margaret Husted. I'm a chartered health psychologist and senior lecturer in psychology at the University of Winchester. So as a health psychologist, that means that I specialise in, not surprisingly, aspects of health, so understanding health behaviours, whether that's in terms of how people engage with health practice, health policy, their actual behaviours they undertake themselves, so understanding the behaviour, but also as a health psychologist, we specialise in behaviour change. So that is in terms of, understanding what we need to do, so interventions we might need to put in place to actually help people optimise their health and change their behaviours and maintain behaviour change over longer term. At the University of Winchester, I'm also the research group lead for the Healthy Lives Research Group, which is one of the research groups within the psychology department. So I have a number of very capable colleagues in that area who may also be able to help you and collaborate with you in relation to your research. So if you're looking at research generally, I'm a good point of contact, because even if it's not something that I personally specialise in, I can quite often hopefully point you in the right direction of someone who can help. I represent psychology as well on the Hampshire Hospitals Foundation Trust and Winchester Research Collaboration Committee, which is something I've done for a number of years, so it's been quite interesting to see how the collaboration has developed, and I think we are making progress, but I'm sure we're all wanting to see if we can grow this as an area even more. Personally, my main areas of research are adolescent health, so I'm really interested in looking at how we can intervene kind of earlier on in people's kind of health trajectory. So by focusing on adolescent health specifically, we can often develop interventions and look at ways that we can optimize health behaviors at this stage, knowing full well that the health behaviors that people can adopt and embed during adolescence tend to feed into the health behaviors that they adopt when they're adults, and obviously as a preventative measure that's quite effective. And again, the earlier that we can intervene, the better. So particularly interested in adolescent health, and related to that, I've been undertaking some sleep research recently, looking at an intervention that can actually improve and help adolescents obtain better sleep quality. My other kind of key area is patient experience and decision making. So that's where I've collaborated with the Hampshire Hospitals Trust on a number of different projects, and I will talk a bit about that in a minute. Also, I'm very keen to improve workforce wellbeing. So the individuals that, like yourselves at the front line, look at ways that we can support you and hopefully give you more kind of optimal experience, whether that's in the workplace or outside, but generally to make a happier, healthier workforce. And it all is underpinned by aspects of behaviour change. So the current research collaborations that I've had with the Trust so far, and some of these are being talked about in other presentations, so I'm not going to talk about them for too long, is I've been collaborating with Professor Richard Hindley, so looking at patient decision making for men with non-cancerous lower urinary tract symptoms. Stage 1 is currently ongoing, where we're doing like a qualitative fact-finding research, and we are now in the kind of main grant preparation time, so we're looking to obviously take this further in terms of developing a patient decision-making aid and working kind of multi-site, but obviously HHFT will be kind of central to that. I've also been working recently with Dr Tamara Everington, so we've been looking at patient treatment experience for individuals who've been experiencing haemophilia. We've completed the first stage of our collaboration, and there is a preprint article available looking at what we found in terms of patients' experience. I also collaborated with Barbara Parry before she has retired. Barbara was looking at having an evidence synthesis of physical activity interventions for people following breast cancer treatment. That study has now finished, and we managed to achieve 2 publications in psycho-oncology, which kind of brings that evidence together from both a systematic point of view in terms of quantitative and qualitative research findings. Other areas of applied research, as I say, at the moment I'm actively doing, so quite a few in workforce wellbeing. So one looking at student nurse wellbeing with a collaborator, Rachel Locke at University of Winchester, and Amanda Lees, who is now at Hampshire Hospitals Foundation Trust as a new member of staff. Also looking at adult social care manager wellbeing, so that with my collaborator Viv Colleran at University Hospital Sussex and Kishpati Sinclair from Chichester. And then finally, workforce wellbeing, looking at returning to the workforce following breast cancer, and that's with Andrea Gibbons and Kim Bradley Cole, and I believe Andrea Gibbons has got a specific video about that if you'd like to find out a bit more. And then, as I mentioned earlier, with my collaborator Deborah Gay, we are looking at improving adolescent sleep and health behaviours, and specifically looking at online and app-based intervention, so things that are quite easily accessed but also cost efficient and can be kind of accessed across wide areas. So this is a whistle-stop presentation, as you know, so thank you for listening. Hopefully it's been at least giving an indication of the kind of research and collaborations that I currently undertake and that I'm willing to look to develop. So please do get in touch if you would like to chat about research ideas or opportunities. Please use my email, so margaret.husted@winchester.ac.uk, and I look forward to hearing from you.
Okay, so that's the end of our first presentation. The second presentation will be from Dr. Andrea Gibbons, also a lecturer from the Department of Psychology. Andrea's main research interests are broadly within health psychology and specifically relate to issues around the impact and management of chronic illness. Her presentation is on returning to work after a long-term condition, future collaborations.
Talking to you about a new research project that we're developing called Returning to Work After a Long-Term Condition. So just to give you a little bit of background, there's an estimated 18 million people in the UK that have a long-term condition, and that number will only grow in the next number of years. What's important, I suppose, of those 18 million people, most of them are of working age, but employment rates in these groups of people is quite low. So, for example, one kind of condition that falls under this title of long-term condition is cancer. And people who have had cancer are 1.4 times more likely to be unemployed compared with the general population, despite, you know, a vast majority of these people being willing to and actively searching for employment. Now, in terms of employment, it's really important for financial stability and for kind of psychosocial needs like self-identity, well-being and quality of life. But when you look at it in terms of returning to work or maintaining work after a diagnosis of a long-term condition or treatment for it, it can actually also be linked to improved physical recovery and rehabilitation. So it's not just the financial side of returning to work that's important, but it's also the psychosocial and kind of physical aspects of it too. There's been a lot of research that's looked at the kinds of barriers and facilitators to returning to work for people who've had a long-term condition, particularly with, cancer or, after renal failure that's required a transplant. But actually, they tend to focus on return to work as an end point rather than looking at the experience of returning to work, which, depending on the experience, may mean that someone will retain their job or be more likely to leave and then end up unemployed within a short time frame. So this research program that we're developing in psychology, and we hope that members of the HHFT will be interested in collaborating with us, is to we've got two different kind of goals. We've got short-term goals, which I'll talk about in a second, which is assessing the experience of return to work in women who've had breast cancer. But actually, from that initial study that we're going to be setting up this year, we want to consider how our findings can transfer to other conditions, not just other types of cancer, but people who have renal conditions, those who've required a transplant, for those who've had a stroke or have had a heart disease that has required, long absences from work. Looking at how we can transfer what we find about returning to work after these conditions to a number of applied contexts. And in the longer term goals then is to collaborate with organisations as well as hospital trusts, so that we can find out how best to implement support to people returning to work and help people make this transition. And really, this will help inform kind of future grant applications where we can look at developing interventions that can be applied across a number of settings. So the initial study we'll be running this year is called Exploring Women's Experiences of Returning to Work After Treatment for Breast Cancer. So this is a small qualitative study that's going to be focusing on the lived experiences of women returning to work in a large organisation after breast cancer diagnosis. The aim is to recruit 20 women and interview them online, and they'll be recruited through social media, adverts through large organisations, and snowball sampling. To conduct the interviews, we'll be using the River of Experience tool, which is a drawing tool from a constructivist approach that allows women to tell the narrative of their cancer journey and their transition back to work. And in this way, it will allow them to talk about both the personal and organisational experiences of returning to work. We'll be analysing the data using thematic analysis, and we'll disseminate the results via journal publications. But I suppose what's important is that we'll be using the results to support future grant applications for the next stage of the project, which will be to develop, a programme that will help improve the experiences and the transition back to work for women with breast cancer. And then, further on looking towards our longer term goals of, seeing if we can transfer that to other conditions, to other larger interventions. So the research team that's currently involved in this research program is myself, Dr. Andrea Gibbons, as well as Dr. Margaret Husted and Dr. Kim Bradley Cole, and we're all in the Department of Psychology. But I guess I want to make sure that you know that we are very happy and willing and excited to collaborate with any of you who are interested in any way. So please contact us if you are interested in talking a little bit more, or if you think this might be useful for any kind of patient groups that you might be working with. And thank you for your time.
Okay, on to our next presentation. So this is going to be led by Dr. Sarah Golding, a researcher in the Department of Psychology as well. Sarah's research interests are applied in nature and focus on issues of public health, health inequalities, health environment interactions, and sustainability. Her presentation will be on exploring treatment decisions in men with lower urinary tract symptoms.
Hello, my name is Sarah Golding and I'm going to give you a quick overview today about our ongoing qualitative study that's looking at the different factors that influence men's decision making when they're considering their treatment options to relieve lower urinary tract symptoms. The project is a collaboration between the Department of Psychology at the University of Winchester and the Urology Department at Basingstoke and North Hampshire Hospitals. Richard, Margaret and Deborah are the co-principal investigators leading the study, and I'm the researcher conducting the interviews with participants. And we're being supported in our efforts by the wider urology team at Basingstoke and North Hampshire Hospital, who are supporting us with recruitment, and we're hugely grateful for their efforts in reaching out to identify potential participants for us. So as a bit of background, it's quite common as men age for their prostates to become enlarged, which can cause interference with urination and can also cause problems with sexual function. And common symptoms include needing to urinate much more frequently or much more urgently, and also disturbance during the night. The condition itself is not necessarily life-threatening, but it does interfere with quality of life. The condition is treatable, and there are several different treatment options available with different medications and different surgical procedures that are more or less invasive. But each of the different treatment options that are available comes with their own kind of profile of risk versus potential benefit, and none of the treatments are guaranteed to deliver significant improvements for every single patient. And they each carry different profiles of potential side effects. And additionally, whilst there's been a lot of previous research exploring the treatment decision making in men with prostate cancer, there's been relatively little exploration of the treatment decisions made by men when they're considering treatment for a benign condition. So the study, therefore, it aims to understand more about what it's actually like to live with LUTs, lower urinary tract symptoms, as well as gain insights into the different factors that patients are considering when they're deciding between their different treatment options. In terms of who's eligible to take part, participants are eligible provided they are men aged between 45 and 75, that they speak English fluently enough to take part in the study, and that they have full mental capacity. Participation is completely voluntary, and participants provide informed consent that it's made clear to them that participation is entirely separate from their treatment options, their treatment pathway. But they do need to have a diagnosis that's non-cancerous and to have undergone a consultation with a urologist about potential treatment options that are open to them during the previous 6 months before they're enrolled into the study. So as I mentioned at the beginning, the study itself is using a qualitative methodology. I'm conducting one-to-one in-depth telephone or Zoom interviews with participants to explore the research questions. And the interview questions themselves, they're focused on understanding what it's like to live with LUTs and also what's prompted participants to seek help for their LUTs, as well as seeking to understand their thoughts and concerns and other kind of influencing factors on their treatment decisions. We're looking to recruit around 40 participants in total, with recruitment taking place, as I mentioned, via the urology team, via outpatient clinics at Basingstoke and North Hampshire Hospital. And the interviews themselves, they're being audio recorded and then they'll be transcribed and analysed using an approach called thematic analysis, which is a very common approach to understanding what's happening in the data and is commonly used in these kind of health psychology studies. So in terms of the expected outcomes, we anticipate our study will be able to provide insight into what it's actually like for men to live with LUTs, how it impacts on their day-to-day life, their quality of life, and also what it's like for them to go through the process of deciding between the different treatment options. The results themselves will be shared locally with the urology team, as well as via academic publications and conferences. And the results are also intended to support the writing of grant applications for the next stage of the project, in which we hope to develop and test some kind of decision-making tool or aid that can be used by patients and or by clinicians to help assist patients in their treatment decision-making. And that's it. Thank you very much for listening, and please do not hesitate to get in touch with the project team if you have any questions at all.
Okay, our next presentation is to do with future collaborations and the effect of magnetic field therapy on pelvic floor activity and function. This is very much a collaboration between the Trust through Geetika Shah, a gynecology registrar, Christian Phillips, a consultant in gynecology and also a visiting professor at the university, and Catherine Cook, a senior lecturer in physiotherapy in the Faculty of Health and Wellbeing.
Hello, my name is Geetika Shah and I'm a specialist obstetric and gynecology registrar working for Hampshire Hospitals Foundation Trust. Our study is looking at the effect of high intensity focused electromagnetic technology on pelvic floor activity. I'm doing this project with Dr. Catherine Cook in the photo above, who is part of the University of Winchester Physiotherapy Programme team. She has an interest in women's physiotherapy and health with an interest in objective measurement. Professor Phillips, in the photograph below, is a visiting professor in the university's Health and Wellbeing Research Group. He is also a urogynecologist and clinical lead for gynecology for Hampshire Hospitals Foundation Trust. Now for some background to our study. Stress urinary incontinence and pelvic organ prolapse are chronic health conditions which have a significant impact on women's quality of life, with important social and economic implications. They affect about 50% of women during their lifetime and 20% require surgical treatment. National guidelines, such as NICE, currently recommend pelvic floor physiotherapy as first-line treatment for these conditions. Physiotherapy is believed to improve stress urinary incontinence in up to 70% of patients when compared to controls. Currently, conservative treatment options are limited, which is why there is interest in finding alternative and adjuvant treatment options. High-intensity focused electromagnetic technology is a non-invasive extracorporeal treatment which is delivered through devices like the chair in the photograph above. It's believed to be a safe and painless treatment which causes sustained contractions of the pelvic floor muscles. It's believed to cause hundreds of contractions over a cycle of treatment. Current evidence, however, is very limited and of poor quality, which is why we're doing this study. We are going to do a pilot study looking at the impact of high-intensity focused electromagnetic technology on pelvic floor muscles in healthy volunteers. Participants will receive 2 sessions a week, lasting 30 minutes each over a period of 4 weeks. Outcome measures will include activation of the pelvic floor muscles using the Maple device, as shown in this photo, which is a vaginal probe giving real-time, sensitive and multi-directional data. Validated genitourinary patient-reported outcome measures will also be looked at. We hypothesize that high-intensity focused electromagnetic technology increases pelvic floor strength as demonstrated by an increased electromyographic activity in the pelvic floor muscles as measured using the Maple device. We want our study to build a more connected and integrated research team between the University of Winchester and Hampshire Hospitals Foundation Trust. We have applied for a grant from ARC Wessex as part of their Research Initiation Award, which is still pending. We want our study to inspire more healthcare workers to do research and hope it leads to future research collaborations. Our aim is for this collaboration to improve the health and well-being of our local community. If high-intensity focused electromagnetic technology is proven to be effective at strengthening pelvic floor muscles, this may lead to future research and ultimately a new conservative treatment option for stress urinary incontinence and pelvic organ prolapse. Thank you for listening to our presentation today, and if you have any questions about our study or are interested in participating, please contact me on my email address below. Thank you.
Okay, our 6th presentation is from Helen Ryan-Stewart. Helen is a BASES accredited sport and exercise scientist, chartered scientist, and a level 3 Isaac anthropometrist. She works as an exercise physiologist in the School of Sport, Health and Community, and her presentation is on using exercise interventions to support those experiencing long COVID.
Hi there, my name is Helen Ryan-Stewart and I am a sport and exercise physiologist here at the University of Winchester, and I work alongside Dr James Faulkner, and I would like to give a brief presentation on a potential collaborative project that I would like to have discussions with staff members about if anybody is so interested. And it involves the use of exercise interventions to support those patients who may be experiencing symptoms of long COVID. So in terms of long COVID itself, there is a well-established database of information about the numbers of people that appear to be suffering with long COVID. So the Office for National Statistics in itself is doing quite a bit of data mining in this area, and are demonstrating that there is an estimated 1.1 million people in private households that are experiencing the symptoms of long COVID, so symptoms that are lasting for more than 4 weeks after their first coronavirus diagnosis. For some people, these symptoms can subside relatively quickly, so within that 4 to 5 week period, but for others, and around 1 in 10 patients who have tested positive for COVID, these symptoms can last for 12 weeks or longer. One of the biggest stumbling blocks with long COVID itself is that there doesn't appear to be currently any universally agreed definition of what long COVID actually entails, but it does appear to cover a relatively broad range of symptoms, and the most common ones of those are usually fatigue, muscle pain or myalgia, and difficulty concentrating. In more recent times, there's been a surge in the amount of research data that's coming out about COVID and long COVID in particular. And the paper presented here on this slide used a COVID symptoms study app with data from the UK, US and Sweden to demonstrate that in just over 4,000 cases, around 20% of those people who tested positive for COVID experienced some form of prolonged symptoms. But that these symptoms were over different time courses. So it appears that not only is long COVID complex in terms of its actual range of symptoms, but that it's also complex in terms of how long it can last for different people as well. Experienced more than 5 of the normal symptoms associated with long COVID during the first week of illness was positively and strongly associated with actually developing long COVID. So the 5 symptoms that most predicted long COVID occurrence during the first week were fatigue, headache, dyspnea, hoarse voice and myalgia, although those do differ slightly for the over 70s. Now, the reason why I feel there could be a potential collaboration here is that the issue or the impact of long COVID is that it is having an adverse effect on the day-to-day activities of thousands and thousands of people living in the UK, and that many of those individuals are reporting that their ability to undertake day-to-day activities is quite severely limited. And this chronic support is also putting a further strain on already very strained healthcare systems. So we know that exercise rehabilitation programs are well established in other clinical populations, and the article that is cited there is a position statement from the Healthy Living for Pandemic Event Protection Network, and they've provided a collaborative blueprint that effectively is attempting to try to develop research and clinical guidelines to help people find appropriate methods of treatment for people suffering with long COVID, and exercise rehabilitation appears quite regularly in this position statement. So this potential collaboration has really been born from the fact that at the university we have the experience and expertise in providing the Help Hampshire support to stroke patients and a rehabilitative programme for that clinical population, and we'd like to build on that model for other populations. Given the recent pandemic, it would seem an opportune moment to try to build a similar programme or look at a series of research studies that look at potential treatment and rehabilitation with exercise for those suffering from long COVID in the local region. So I'd be really interested to hear from any of my colleagues at HHFT who would be interested in taking this further and discussing this collaboration further.
Okay, on to the final couple of presentations. These final presentations are linked to undergraduate dissertation work, where there could be substantial capacity to grow undergraduate dissertations with work being conducted at the trust. This first one is by Sarah Wilcox, a third-year physiotherapy student at the university.
My name is Sarah Wilcox and I'm a final year student on the physiotherapy programme at the University of Winchester. Today I'll be providing a brief overview of my dissertation in the use of mobile health applications in an orthopaedic setting. My dissertation comprised of a scoping review looking at the mobile health apps available to support rehabilitation following knee arthroplasty, subsequently making a recommendation of one for trial and implementation. It has been established that total knee arthroplasty should be available for all, regardless of age or predicted level of function after surgery. Indeed, with an increase in the ageing population in the UK, there is also an increase in the rehabilitative burden before, during and after surgery. The pandemic of 2020 also forced health organisations across the globe to alter their ways of working to reduce face-to-face contact. Mobile health apps have been shown to provide a unique way of connecting clinicians and patients at a distance, permitting flexibility in their function, design and accessibility to suit various patient populations. It is recognised that patients must be part of the rehabilitative process. Indeed, studies have shown positive effects of mobile app use on the post-operative outcomes in orthopaedic and cardiac patients. In May 2020, I made contact with Jana Junis, the Band 7 physio on the orthopaedic ward at the Royal Hampshire County Hospital, who outlined their aspiration to drive patient care forward with the potential to use innovative means in doing so. Following a service transformation in 2019, the trauma and elective arthroplasty services separated to two sites between Winchester and Basingstoke. Winchester is now striving to become an elective centre of orthopaedic excellence for lower limb arthroplasty within the UK. Jana and her team were poised to adopt an innovative approach to optimise self-management by patients in order to maximise their independence and chances of a positive clinical outcome. They understood the potential of what mobile health applications had to offer, but were limited in their capacity to carry out research to identify and review what was available on a saturated health app market. Once I had created my dissertation brief, I needed to identify apps suitable for review. Apps were selected if they were patient-directed, arthroplasty-focused, available in English and free of charge at point of access for the patient, in keeping with the NHS provision of services. Apps which did not meet the criteria listed were excluded. I utilised both Google and Apple stores to source apps, as these systems are the most widely used. Indeed, they accounted for 99% of all app sales in the first quarter of 2019. This slide shows the search strategy I employed. Following initial identification of suitable apps, the resulting ones were listed and duplicates removed. They were then screened for suitability, and following this process, 9 apps remained for review. If an app was available on both operating systems, the iOS platform version was preferred as default to maintain consistency. Each app was downloaded for review and additional information obtained from the app stores to provide a comprehensive overview should Jana and her team require it. To review the applications, I used the Mobile Application Rating Scale, or the MARS. The MARS is considered one of the most established review methods, offering simplicity and objectivity in reviewing health-related applications, and has been trialled with studies utilising just one researcher, which then lent itself to the way my dissertation was to be carried out. Indeed, it has been used to scientifically review app quality in fields such as depression and pain, to name a few. The MARS allowed me to assess each app on 4 quality dimensions: engagement, functionality, aesthetics and information quality. Upon recommendation by the MARS creators, video training was also undertaken using sample rating exercises for practice. An excerpt of the Mars tool is shown here. The app quality dimension consisted of a total of 19 subcategories, and each app was reviewed for use by both patient and clinician. All items were rated on a 5-point Likert scale, from 1 meaning inadequate to 5 meaning excellent. The infographic illustrates the results of my research. Northumbria NHS Trust utilises My Patient Journey, a platform also used by East Kent and Milton Keynes NHS Trusts. My final recommendation was that HHFT investigated the use of this platform to personalise and adjust for specific use. In order to provide an understanding on the delivery and operation of the app at an operational level, I sought further advice from physiotherapy staff at Northumbria Trust who had been using this app for the past 2 to 3 years. Future RCTs could characterise the use and efficacy of this app on patient health knowledge, behaviours and use, thereby optimising their rehabilitation and improved quality of life following total knee arthroplasty. Ultimately, it could be a conduit to reducing the burden on public health and clinical systems.
Okay, and on to our final presentation, which is again another student presentation by Molly Harrison and Laura Thomson, who are current third-year BSc physiotherapy students.
Hi, I'm Laura and this is Molly, and we're third-year physiotherapy students at the University of Winchester. And today we're going to do a short presentation on our collaboration with Hampshire hospitals for our dissertations. So the stroke ward at the Royal Hampshire County Hospital conducted some multidisciplinary team simulation training for their staff at the beginning of 2019. This training involved use of role play to recreate clinical scenarios that may occur in the ward setting. So our aim was to explore stroke MDT perspectives following the simulation training. And we specifically wanted to investigate effectiveness of the training and whether it improved staff confidence in live clinical situations. Furthermore, we looked to identify how training could be improved in future sessions to provide best learning experiences for staff within the stroke MDT.
So to gather this research, we conducted semi-structured interviews with the staff via Microsoft Teams due to the COVID-19 pandemic. The members of staff that completed these interviews were a variety of disciplines, ranging from Band 2 to Band 6 of therapists and healthcare assistants. We did offer it up and we used the convenient samples to see who was able to complete these interviews. They were recorded and transcribed, and then using thematic analysis to identify the themes from the data.
So the main themes identified are shown on this slide. There was good retention of own scenarios. Staff found they were able to recall their own scenarios and how they responded to them, but had lower recollection of scenarios they were only observing. There was the requirement for regular training. So while all staff felt confidence did improve following sim training, all felt regular training would be beneficial to retain information. All staff deemed training as an MDT as beneficial. So this enabled them to view other team members' roles in action and appreciate how different specialities complement their own job role. And although participants referred to a feeling of uncomfortableness during role play scenarios, they recognised importance of role play when mimicking real life situations and found them preferable to other means of learning such as online or classroom based. So ultimately, staff reported confidence improved if a situation was to occur in the clinical setting following the training.
So finally, we looked at the conclusions and recommendations from our research. Firstly, simulation training improves staff confidence in future clinical situations. MDT training is beneficial and should be considered over single discipline training, which shows a diversity amongst groups being useful. Regular training can help ensure retention of learning. Roleplay, and finally, roleplay should be considered over other means of training to provide realism to the scenarios. These are ways in which staff reported that they would find the training better or should be continued in the training that they have already had. Thank you.
So that's the end of the collaboration session. So many thanks to all the presenters from the university who contributed. And as I said at the start, there are some additional presentations that will be available at lunchtime. So thank you.
Brilliant. Thank you, James, and thank you to all your colleagues for an excellent set of presentations. We're not taking questions now, but obviously they were all really good at providing you with their contact details. And